I'm going to start us off for today. Good morning, everyone, and thank you so much for joining us. My name is Kate Toomey, she, her pronouns, and I am the Sexual and Reproductive Health Project Officer at the Centre for Excellence in Rural Sexual Health, also known as CERSH. I'd like to welcome you all to Promoting Gender Equity in Health Through Data, which is part of CERSH's Sexual Wellness Professional Development Series. And today's session will be presented by Jenny Ward, whom I will introduce shortly. Before we begin, I would like to acknowledge the traditional owners of the lands and waterways across Victoria and Australia, which we are all joining from today. I'm joining you from Dja Dja Wurrung country, and I'd like to pay my respects to elders past, present, and emerging, and I'd like to extend that respect to any Aboriginal and Torres Strait Islander people online with us today. I also want to acknowledge the deep importance of Indigenous knowledge in the field of sexual and reproductive health. Wherever we are zooming in from today, we are all on Aboriginal land and sovereignty was never ceded. Now, before I introduce Jenny, a few housekeeping notes for today's session. We kindly ask that everyone stays on mute during the presentation, but please feel free to share your questions in the chat as I will be actively monitoring it throughout. Also, this session will be recorded, so if you prefer not to appear on screen, I highly recommend you switching off your camera. Like I said, we're recording today and this will be available on our website next week. So you're more than welcome to revisit it there along with our past sexual wellness webinars. Now, it is my absolute pleasure to introduce you all to Jenny Ward. Jenny is an information services specialist with 40 years experience in women's health. Jenny has worked at King's Edward Memorial Hospital, the Royal Women's Hospital, and spent the past 17 years at Women's Health Victoria. Throughout all the changes in the information landscape, her mission has stayed the same, helping people find the information they need. Jenny curates the Victorian Women's Health Atlas, working with data suppliers, updating indicators, and turning complex data into meaningful insights. In March 2026, Women's Health Victoria released an updated Atlas platform with mobile functionality, which we'll learn more about today. Thank you so much, Jenny, and over to you.
Thank you very much, Kate. I'm just going to start straight in and I'm going to share my screen. It may take a moment for the presentation to come up, so just let me know when it's appearing. Is it appearing now?
Yeah.
All right, off we go. So thank you for that introduction. I'm joining you from the Wurundjeri Woi-wurrung country, just north of Melbourne in Sunbury, and I add my respects to the traditional owners of the land and acknowledge that it always was and always will be Aboriginal land. So today, this is what we're going to cover. A few minutes on the background to the Atlas, then we'll do an interactive walkthrough and covering how to access the data, how to compare data by various means, the outputs that you can get, and focus on some new data that we've added recently. We'll have a bit of a just look at what the mobile extension does, some related resources, and then we've allowed 10 minutes for a Q&A at the end. And I can assure you that if we don't get time to cover everything, I'm quite happy to answer any questions. If you could put them all in the chat and we can answer some of them afterwards offline, so you get them all answered. Okay, so what is the Atlas? It's a free map-based platform. The aim is to visualise women's health and wellbeing. It covers every Victorian local government area, and we now have over 90 health and wellbeing indicators and a total of more than 700 maps, because some of them have multiple measures and some of them go back 10 years. So the idea is it turns a complex data into a story that you can see. You can, picture tells 1,000 words, basically. So, and that can support action and understanding of where differences are and highlight what is needed. That QR code there is what gets you to the mobile version of the Atlas. Who produces the Atlas? It was developed by Women's Health Victoria, launched over 10 years ago. We work closely with the Victorian Women's Health Services Network, which is important because it was designed to support them, and therefore the regions that the Atlas uses, the 9 regions, are aligned exactly with the 9 regional women's health services, which have been around for over 30 years. We receive funding support from government either through our substantive funding as our organisation, but sometimes we get project funding for the Atlas as well over the years. And our technology partner is Veris, used to be called Spatial Vision, and they've been with us throughout our journey. And they did the major redesign for us, which resulted in the new interface. And we're up for an I award. We're going to the award ceremony next Wednesday to find out if we have succeeded. So we'll see. Watch this space. And for those who might not know, Women's Health Victoria is one of 3 statewide women's health services. The other 2 are Women with Disabilities Victoria and Multicultural Centre for Women's Health. So we are a statewide. Our focus is gender equity and health, and we focus mainly on upstream health promotion, and we focus mainly on the health sector. And we do have some direct services and programs. Some of them you may be familiar with. The Labia Library, which is a gallery of women's genitalia to show the range of what is considered, everyone's diverse, everyone's different. We get millions of hits from all around the world, and people really love the fact that this exists. The Atlas, of course, we have some training, self-paced and also led by educators. 1-800 My Options, which is a statewide helpline and information service for access to information about contraception, medication and surgical abortion, and other things. Like now they run the endometriosis and pelvic pain support line as well. We've got Counterpart, which is women who have lived with cancer, supporting other women with cancer, and In My Prime, which is website celebrating older women's health and body image. Okay, so let's get on to the interactive walkthrough. The slides I'm following, I've got slides based on this, which we can send around afterwards as well, that sort of highlight certain things. But I'm going to now change my sharing and share now the browser tab. So just give me a second to get this going. And I've just got to make sure I'm actually, can people now see what looks like the atlas?
Yeah.
Yes, excellent. All right. So I'm going to have to move everybody around so you're not obscuring my screen. Okay. So this is the new homepage for the atlas. So this is the priority health areas haven't changed. They're in the middle. The URL hasn't changed. It's up the top here. So it's exactly the same, and the data is exactly the same. It's just the way it appears is different. And now if you open it on a mobile, it won't say computer says no. It will actually let you do things. So if you want to find out what's changed, you can click on this to read about it. And these things in the side panel, these now reside over in the main WHV website, and we'll cover some of them at the end. Anyway, let's go straight in. So I'm going to use examples just to illustrate things. Obviously, it's only a selection. So if we want to choose a priority area, let's start with cancer. Click on that. Now all of the indicators are sorted in alphabetical order. It used to be an order that made sense only to us. So now it's A to Z and you can easily find things. So we're going to choose breast screening. And then here we have a choice. We've just got the one measure, 2-year participation, and we've only got one sex there, female. So then we'd show that. It always starts with the statewide view as previously, with the overview text showing. Used to be on the left and now it's on the right. A couple of things that have changed. First of all, it's designed so that nothing obscures the map area. So when you open things, they no longer cover the map, and we've tried to keep it clean and clear. Up here you have the geography that's being shown. So it's state. You can choose region or you can choose metro there, but I'll go back to state at the moment. The key, what the colours mean, is travelling along below there, below the map. And below the map is geography you've chosen, Victoria statewide, and across to the right it's telling you the statewide figure for female. Now, it seems far apart, but when you go to mobile view, that tends to consolidate left to right and become closer together. So it's a responsive design that allows for that, which is why it's like that. Below the map, we still have the bar chart, which has one bar for every local government area shown on the map, and they sort lowest to highest in value. All of the colours in the atlas are now in the yellow, blue, green family, where yellow or light green is lower value, blue is a higher value. We no longer have traffic light indicating something may be good or preferable, or bad or worse. We've done away with that. So now just the higher depth of colour means a higher value, and then you read what that means. Um, so up the top, we have, up the top left, we're looking at the cancer priority health area. The indicator is breast screening.
Sorry, Jenny, we've lost your sound.
I'll just unmute. Am I back?
Yes.
Ah, okay, cool. Yeah, that something, it said the host muted me there. Um, so yeah, the indicator breast screening, and this is where you can change it to something else here. It's showing the measure, the sex, and the time period. So let's say, okay, well that's great. What if we wanted to know the data trends? Instead of them opening up in front, over here we have data trends panel. If we click on that, what it does is show 10 years of data mapped in a plot graph. You can see the influence of COVID there quite starkly as it drops down and comes back up again. We've improved the labeling such that compound years are now shown in full. It used to be the ending year. So now it shows you it's 2 years each time. And that's also in the table below. So the table has up to 5 years or time periods, and the chart has up to 10. So it gives you really at a glance view of what's happening. So let's say we wanted to choose a region. Let's pick a region up the top here. And this little I thing, information thing, will tell you the regions match the Women's Health Services and take you to where you can find out more about that. Because we do get asked, why are you not doing local health service networks? Why are you not doing PHNs? Why are you not doing integrated cancer services? So we're proudly doing the Women's Health Services, and that needs to be explained a bit better, which now we do. So let's pick Goulburn Northeast. So this is a new feature. What happens now is it's possible to get region level data, summary data in the mapping. We never had that before. So now if you don't click on an LGA, you'll see below the map, we now have Goulburn Northeast with the summary value for Goulburn Northeast. And at region level, you'll notice the labels turn on with the bars, so you can see the names of them, which is helpful if you want to do a screenshot or an output. And over on the data trends panel, we now have charting Goulburn Northeast, which interestingly seems to have gone way up after COVID, and we'll look into that. And in the table below, it's now comparing the Goulburn region average with the state average. So that's sort of interactive and it changes according to what you're looking at. So you can benchmark different things you may want to benchmark. So now if we wanted to look at LGA level data, let's click on an LGA. Let's click on Wodonga. And now something very interesting can be seen in the data trends, which we'll explain. So even though you can see that Goulburn Northeast looks quite even in the current breast screening, it's not a lot of difference. They're within two colour ranges on the chart, which is good. You can immediately tell over to the right something strange has happened there with Wodonga, where it's been tracking very low and then suddenly jumped up to high 40%. And why is that happening? Now, if you were to look at the text next to each map, that would tell you the answer to that, because it tells you that as of a certain date, breast screen started to include the New South Wales cross-border screening data in their data. And to see that more clearly, what we can do is what's called compare data sets. And this is a very powerful feature. So we're starting with one map. We're going to add another one beside it. We're going to use the exact same thing, but we're going to change the years. So I'll go into Goulburn Northeast again. And on this side, I'm going to go back a couple of years. Ah, it always does that. We're going to change that because it zips back out to statewide view. And you can see what a massive difference there is in the mapping when before we had the cross-border screening data. Look what the situation was, and it actually was screening was as low as 1% in Wodonga when you only used the Victorian data. But when they brought in the New South Wales data, you can see it equalised quite nicely. So now we can see that that was really a sort of a false indicator there because it didn't include the cross-border screening. And the notes, if you look at the notes for this earlier period, it tells you why it's low in those years. And if you look at the notes for the more recent one, it tells you that that New South Wales data has been added. So the explanatory notes change according to what year you're looking at. So, so that's reassuring, and it means we don't necessarily need to then worry about that. Now, looking at another region, I'm just going to go back to a single view, and I can just turn one of these maps off. Now I'm going to go to Loddon Mallee and go back to the current year because it was still showing an earlier. It's very easy to change things at a click of a button. You can see how responsive it is. Now with this one, see how much more polarized Loddon Mallee is with its breast screening rates, and that would immediately think, now what's happening? What can we do to increase screening in these areas? And in fact, as of June 2024, Swan Hill is the lowest in the state. And if you look at it, it's considerably lower. If you look at the data trends, something has happened where it dropped right down. But so obviously action would be needed. And fortunately, there has been action because this is on a slide, but I'll just tell you what it is. In The Guardian in March 2024 was a story saying they'd opened a permanent breastfeeding clinic in Swan Hill to overcome the issue that of the mobile van not meeting the needs. So we would expect when we get the next data, which we'll get soon, we would expect that to come up again. And so it would match the other LGAs. So it just shows how you can use data to advocate for services, to show quite clearly that something needs attention. And it makes a very compelling case when you see it on a map like that. We try and figure out, can we explain this? Do we know it's happening? If we do, fine, we can explain it. If we don't, we can advocate, we can talk to people, we can try and make something happen. So this is why the data visualization is so powerful. Okay, so now let's move on to one of our beloved indicators in the sexual and reproductive health section. We're going to look at medication abortion. And the reason why this one is so powerful is because we pay for this data disaggregated three ways. It's disaggregated by where the patients live, where the prescribers are prescribing from, the location of them, and where the pharmacies are that are dispensing the scripts. So we can compare access by where people live compared with where those services are provided. And that's very interesting. So let's start by looking at medication abortion, the number of scripts, and we'll first look at statewide. So there it is. Obviously, it varies, and the number of scripts quite often can vary. I'll better get rid of Swan Hill. See, it's still clicked. If I click away now, I get the statewide. So we can see, obviously, that would suggest that there's a higher number of scripts where there's higher populations, and that's pretty clear that that's happening. So that we can't really compare them from area to area if we only look at the population. So that's why we have the rate per 1,000 people of reproductive age. So let's focus perhaps on Gippsland this time. And what we're going to do, that's the number of scripts, which again is highest in Latrobe, but let's compare that with, again, the same medication abortion, and let's look at the rate of scripts per 1,000 people. It actually didn't change there. I'll just change it again and zoom in. Okay, and now we've got the count, the number of scripts on the left, which is very aligned with population. On the right, though, we have the rate of scripts, and we can see the rate is remarkably even by where people live. So in most parts of Gippsland, it's a fairly similar rate of per 1,000 people of reproductive age accessing the medication abortion scripts. So that that looks pretty good. But let's look at some measures of supply. So now on this side, well, I'll leave the over here the patients on this side. On the left-hand side, let's change it to the rate of scripts by uh, pharmacy location. There it is. And now you can see, there's a bit of variation there. In not all LGAs is there an equivalent rate of pharmacy dispensing. Some of them are higher, some of them are lower. So that might mean we should advocate to say, can we get some more pharmacies that are willing to dispense these particular scripts? So that's something where 1-800-MY-OPTIONS might be involved in doing that. And local agencies might also, the Women's Health Services and agencies such as SERSH could try to influence that so that it became more even. And then if we look at, let's just see if it's always been the same. So what I'm going to do is I'm going to change now these to make them exactly the same. So now I have pharmacy location, and I'm going to change this one on the left and go back to 2017. And what you can see there is in the years between 2017 and 2024, there's been considerable progress in increasing the rate of dispensing in Gippsland region. So even though it's not yet even, it's improved a great deal in those 7 to 8 years. And that's a success story that we can show progress. We're not quite there yet, but we're getting there. So now let's see what's happened in terms of prescribing. So I'm just going to change these both now to the rate by prescriber location. And so that one's 2017. And this one on the right will change to rate by prescriber again. And we can see that one was even more of a change because, in fact, in here we had 0 prescribing in Wellington or Latrobe in 2017 of medication abortion scripts. And this is now changed considerably by 2024. So, yes, it's still not even, but again, good progress has been made. So this is how you can use the atlas to show whether things are improving or not improving. And if we went back to a single map, if we just got rid of one of them here, went to data trends, went back to Gippsland, we can chart here the rate. We can show that change quite well through the chart as well. So there's different ways we can show that that has improved over time, and it's rising to gradually meet the patient demand. So that's why we've got such good layers for this. And I can tell you that we've just purchased recently PBS data, also split by where patients live, where prescribers are, and where pharmacies are for Implanon implant, Mirena IUD, and Kylena IUD. And we're about to map these. They should be in the atlas by the end of the year. It's about 100 data columns because some of them go back many years, as long as they've been on the PBS. So we're doing that to replace the data that we withdrew. We withdrew some data on LARC, on Implanon, and it was for insertion of it. Unfortunately, we found out that insertion of it included Implanon, but it also included other things that were inserted, and we felt we couldn't rely on that data. Most of it was Implanon, but not all. And so out of concern for accuracy, we've withdrawn that and we're replacing it with the PBS data, which is specific to those particular things we want to track. And that there's different doses and as well in those hormonal IUDs, so they're each going to have their own indicator and be separated out. So that's something to look forward to. We'll be able to have that soon. So another thing that we have is for outputs. What can you do? Well, there's a couple of things you can do. For any single map on the screen, we can output it. This little print view thing here, you can click on it, and what it does, it will throw this into a PDF with the map on the first page and the text on the second page. So you can see it there. So this you can download, you can use it for whatever you want to do it for. So it's nicely formatted. If you had clicked on anything, then it would be clicked in the printout. So whatever you've selected is what it will do. Now, am I back to my map? I hope I am. Can someone just nod if I'm back to my map, or am I good? So the other thing you can do is we have fact sheets which are customized for every local government area. And so these are over on the right-hand side here. And so there's two ways to get them. You can either, when you're in the map, get them, and it's already assuming I'm looking at sexual and reproductive health, or you can go right up to the top and not go through any maps at all. And I'll just try and there's an option up here. It's because some people like to get them without going through any maps. So that's up here. So I can get the statewide fact sheet for sexual and reproductive health, or I can choose an LGA. So I might want to click something on the map. Say I just see which one Wellington was the one I was. Hang on. All right, there it is. And I can download that. And what that will do is for every one of these sexual and reproductive health indicators that we have, it's going to reproduce some information customized for Wellington. It's also telling you there's a women's health service in that area called Gippsland Women's Health, who are experts in that area if you would like to get them on board with anything.
Sorry to
And if,
interrupt, Jenny, but I don't know if you want to be shown the fact sheet, but if you do, we're currently looking at the map.
oh, okay. Well, that's interesting. Okay. So I wonder why it's not doing that. Well, that's not very good, is it? Hang on. I'll go over here. Now, can you now see something that says access fact sheets?
Yeah.
Good. Let's try this way. So this is going in from the top. So we want a local government area. We want Wellington. Okay, sexual and reproductive health. Download. Now, it might still, is it now showing that or not? No.
No, it's not.
Okay. Well, look, what I'll be able to do is go back to my slides and show you. So I'll leave that for later, and we'll go back to that in the presentation. So thanks for telling me that. Anyway, yeah, I can't explain it till you can see it. So we'll carry on, and we'll just look at a couple of other examples of things. All right. So a couple of other things you might be interested in. If I go back to the mapping now, you can always go back to the maps using this icon at the top left. So that's a useful thing to know. Sexual and reproductive health. Some of the ones we've added reasonably recently, the problem is that we can't actually update them due to a freeze on data requests through the health department. They're doing them for their internal workings, but we're considered external. So we're lobbying. But at the moment, I can't update these. So if we look at, say, hysterectomy, and we have a look at Loddon Mallee region, we can see that the rates of hysterectomy are quite varying around. And if you look at Grampians region, about 8 of the 10 highest are in Grampians, and these ones adjacent are also high. So that's interesting. And can we explain that? It does not distinguish the reason, whether it's for example, cancer or heavy bleeding or what it may be for, but where the rates are much higher than elsewhere, it's something that is being looked into. And it may somewhat be dependent on the age profile of some of these local government areas as well. There may be more older women, which would make it more likely that these procedures may be recommended. So again, a lot to look into there. So we only have this one for a few years, and you'll find in the various regions, it really varies as to whether these are going up or down, staying the same. And so there's quite a bit of information that you may want to look at. But in this case, Bull Oak is the highest in the region. And oh no, sorry, Central Goldfields is the highest, Bull Oak second highest. If you have something happen like that where the map has gone very small, this map over here, this Victoria icon, just brings things back to Victoria, and you can kind of start again and reset yourself. You can also use your mouse roller to roll out and in to do things you might want to do with those maps. And you can also do a screenshot that will have everything you can see here. So you've got your map, your data trends, and your bar chart all on the one screen. That was previously not possible. Another one you might be interested in here is if we change, we can look at endometriosis. This is hospitalization for endometriosis. And again, we see this one is again high for Central Goldfields, and Bull Oak again the highest, which is interesting. So that might be something to look into. Can we explain what's happening there. Um, and now let's look at one where you can compare the data by sex. So far, we've looked at data that's just female only, but many of the indicators in the atlas have data for both males and females. And within sexual and reproductive health, that's all of the STIs and blood-borne viruses. We have male and female data for that. So let's have a look first at chlamydia as an example. And I'm using the rate because we can compare regions. So we'll start with female, and this time we'll have a look at Goulburn Northeast again. So over on the right-hand side, you can see very interesting. Oh, hang on, I've got still Central Goldfields. So I'll click away. This will happen to you. Now I've got Goulburn Northeast, and you can see on the trend there that female has remained above male most of the time. There's a bit of a gap there. And again, the plunge due to COVID in rates going down, and this you'll see this for most of the STIs. Most of them have come back up since then. Some fully, some not quite as far. Interestingly, towards the metro areas, we're seeing a great deal of areas where the rates have crossed over so that male is now higher than female for chlamydia in quite a few places. This was never the case 10 years ago. Nearly always chlamydia was highest in female, but part of that was possibly because males were not testing for it. So, it's important to try and figure out, can we understand what's happening here? But in the regional areas, the female tends to still be higher than male in most places, but there are exceptions. So if we wanted to, there's clues as to the fact that there's gender differences here. First of all, we've got the chart would suggest that. We can look at the bars below and see the height of the bars are basically higher for the blues, higher than the dark blue in most cases. That's suggesting. And we also have here next to Goulburn Northeast, the figures are different. The female summary 14.5, male 10.7. So that's all very useful. But what if we wanted to see that visually? We can compare these. We can keep the same thing, choose male. And now zoom into Goulburn Northeast again. And we will try and change this so you don't get chucked out to statewide every time, because the previous atlas didn't do that. So I think that's less ideal. And now we can see we have female on the left, male on the right. And to make the distinction even clearer, what we can do is manipulate the bars. So for the side that represents female, we can turn the male bars off. And on the side that represents male, we can turn female off. And that really helps us to see much more clearly. I mean, this one isn't as stark as some, but it really separates. This is the female data, this is the male. We can visually compare them. And we can still see that for the majority of LGAs, they're much lower than the state estimate, which is all persons, which is this dotted line here. But Wodonga clearly stands above, and Greater Shepparton for female. But Wodonga is, I guess, the one that clearly stands out as being highest for the region and highest for female and male, and well above the state average as well. So that might indicate, well, what can we do there? Can we do anything to bring those rates down? If we then look at another one, we'll just change them here. Let's look at gonorrhea and change it on this side as well. I'll change it to male though. So I've just got, so wise to check what you've got up the top here. So gonorrhea, rate female, rate male. And that one shows quite a bit more difference, where we no longer have exactly the same sort of pattern following on both sides. In fact, we've got 0 for several of the LGAs for female here, nothing. And then they come up. And on this side, very different LGAs for male and female there are higher. So again, very different. So now I'm going to move on to come out of the SRH area and just look at a couple of new data sets that we have that we'd like you to know about, because we've invested some time into putting them in here. So I'll just go back to a single indicator. And now I'll go over to healthy living. So in this section, we've added a heap of indicators from the Victorian Population Health Survey. In fact, we've updated all of this section, half of mental health and quite a bit of chronic disease. We've updated some of these by 6 years based on the 2023 survey, or we've put new things in here. So some of the new ones, we've got access to dental services, access to GP services, and this one, healthcare system trust. This is, do you definitely trust the Victorian healthcare system? So let's go and have a look at this one. And I'm going to just focus in on Gippsland for now. So if you look at this one, so there's a bit of a gender divide here. For Gippsland, we've got 39% females trusting the health system, 49% of males. And one of the reasons I wanted to focus on this is see those little numbers in brackets there? They're called confidence intervals. Now, this is based on sampling a certain number of people in each local government area. So they survey 34,000 people, but it's only about 400 people per local government area. Then it's divided by sex. So you can see at best it's a sample. And so these confidence intervals are there to show you how reliable is this estimate. So it means if we repeated the sample 100 times, we're 95% sure, 95% of the time, the result would fall between that range. You can see those numbers are fairly close together within a few percentage points. So at state level and at region level, you can be fairly sure of the estimates. When you get to LGA level, some of those can really widen, and the wider they are, consider them perhaps not as reliable. And when you get to fruit and vegetable consumption, you'll see wild ranging things, especially for males. And just beware of those confidence intervals. That's what they're for. And we're required to report them because it's not the same as I've counted every instance of a script. I've counted every instance of chlamydia. This is a sample and there's a degree of uncertainty to it. So these being new indicators, we've only got 1 year of data, so there's nothing much in the trends. You see, all you get is 2 points in the graph and 1 row in the table. But if, in the 3 years, the next survey, 2026, when that's available, we hope to add to these. And you'll find there's pretty much a statewide difference of at least 9% in females trusting the health system less than males. And that's very pervasive across the whole of the state, pretty much. And in the text, there's some information, where we have this is about the data set itself. We have some discussion as to why that might be or what may be important about it. How was this data measured and where does it come from? So if you're looking for what we know about it, you can certainly have a look at the information. And for those who've used the Atlas before, you'll see we've added some markdown formatting to this to try and make it easier to read. So the dot points, in some cases, there are live links that you can click on and go to things. And for some of them, we also have, helplines and support services for things that might be more sensitive, such as gender-based violence or mental health indicators and so on. Another one I just want to draw your attention to is in the socioeconomic section. We've got a couple here. We've got multiculturalism. This is, do you agree that multiculturalism makes life better? Which is a very interesting one. And this one is whether you've experienced discrimination in the past 12 months. Let's just have a look here at Goulburn Northeast. Oh, sorry, Loddon Mallee. Now, this one tends to show overall that females were more likely to have experienced discrimination than males. However, what I want to draw your attention to is the fact that the narrative tells you some of the more granular data as to reasons why people experience discrimination, and that the information is different for female and male and well worth reading. So for males, racism was the most common reason, but for females, when you look to things like gender, age, gender identity, your family status or your marital status, a lot of those things, a higher proportion of females experience that. And in the population health survey, it's possible to get this level of data for individual local government areas, believe it or not. Now, we haven't mapped every single one of these, but it is in the data download tables if you needed to go down that road. I know it's not necessarily sexual and reproductive health, but it's one of those foundational type of things that can underpin health and well-being. So we wanted to make sure you knew that these things are in there. And then the last one I want to look at is out of hospital cardiac arrest, which is in the chronic disease section. Well, for this one, we've obtained data from the ambulance Victoria, and we've worked with them to get the information. Now, if we look at just out of hospital cardiac arrest, the totality of it and the rate and so on, what we find is it's much more prevalent in males than females. And you can clearly see that in these charts where males are running twice as high in terms of incidence and rate. But what we're interested in is that there are some other things that affect survivability for women. And this is some other information we've obtained. So one of the things we look at is the percentage of out of hospital cardiac arrest that occurs in a public location. And when we look at this, we find there's a big gender divide and that females are half as likely to have this occur in a public location. And because of that, it's far likely to be witnessed, which means there's no one to intervene. Or it may be a long time before someone comes to their aid. Women are also older on average when they have an out of hospital cardiac arrest. And if it happens more likely in the home, then there's less likely to be a defibrillator present. So all of these things are very important. So that's the map for public location, female and male, the number. And you can see it's quite a different percentage there, far less than half are in a public location for female. And so all of these things culminate in shockable rhythm. So by the time emergency services arrive, what you find is that females have a much lower percentage of being able to be revived or having a shockable heart rhythm. And you can see that quite clearly in the maps where females on the left, males on the right. So, emergency services do everything they can, but by the time they get there, it just shows the importance of, campaigns to look at women's heart health, recognizing symptoms early, community knowing what to do, activities like defibrillator in your street and so on, people being trained, ready to respond, and also not being reticent to rip open the clothing and just start giving assistance, irrespective of someone having breasts or whatever, even having mannequins with breasts for training. Every little bit helps. And so our Women's Health Victoria is doing some work on that to try and increase awareness of this. So that's a crash course in the Atlas mapping. I'm going to now stop sharing that particular screen and I'll go back to now sharing my slides. I'll just have to move that. There. Now I'm going to do a funny thing where I scroll down very quickly to where I couldn't show you something. Right, here's a fact sheet. Can everybody see that now? So that shows that you can get a fact sheet for Wellington. It has medication abortion and all of those in there. And when you scroll down, you get a table that shows the local government area next to the Gippsland estimate, next to the Victoria estimate. So that's what they do, and it just puts it all in one publication for you. So now I'll just go to where I was. So you can get a copy of this at the end if you wish. So now I'm going to talk about the mobile extension. These are some screenshots that show what the mobile extension can do. There's a little message up the top when you first look at it that says it doesn't do everything, and there's a table that you can look at to see what it does and doesn't do. But you can get the map, you can get the text, you can zoom into metro or a region. The maps will change. You can get the data trends panel, but not the graph. You only get the table, and it only has two columns. We can't do the four, so you're only getting the data for the map that you're looking at, and you can download the fact sheets as well. So all of that is in there. Um, so the things that we aim to implement, they may be a challenge. The bar chart is proving very challenging, and we don't know how we're going to do it. We think we can do the plot graph. We think we might be able to compare two maps, one above the other, and the print to print the current map out to a two-pager. Think we can do that. So watch this space. We hope to implement three of those. Maybe not the bar chart, as our programmers haven't found anything that really makes sense yet. Now I'm going to quickly look at some of the things that are on the left side menu that you may want to know about. We have the full list of indicators. You can go to the left menu and just open that and download that. So that gives you everything all laid out in its priority areas. Anything new is marked new. We have some education resources. There's a free self-paced online training module that you can work your way through. You sort of add it to your cart. It doesn't cost anything. But once you've got past that, it takes about 45 minutes to an hour to work through it slowly and answer questions, and you'll be led all around the atlas and you'll have a pretty good understanding of it when you're done. We also have recently launched some education resources for Year 9 and 10 geography, which is now compulsory. It used to be elective in schools, and this allows schools to use local data for their local government area to investigate health and well-being, among other things. And I will be promoting them at a conference in August, a conference of geography teachers. So if you know any schools or you think that might be of interest to anyone in your areas, it's not many places you can get data from Alpine to Yarriambiack, all to the same degree, full coverage. We also recognise the Atlas doesn't have all data for everybody, and there are things we just can't map because we can't get the data. So we have these national and statewide data series. These are just lists of resources, key reports, or statistics that we know of that are not within the Atlas, but you may want to use them for broader context. That's particularly important for different populations, such as the ones in yellow, where it's very hard to get data we can map disaggregated for these communities. And we've got somebody actually revising all of them at the moment. They're now 2 years old and they need updating. So by the end of the year, they should be fully updated, but they're there and they can be utilised now. If you want to, sorry, I skipped. If you want to contact us or leave feedback, there is a user survey you can click on. You can use that to not only tell us about your experience of the site, but at the end you can ask questions, or you can say, why is this like this? Or report a problem or whatever. We'd love to hear. And if you want an answer, please let us know who you are, because sometimes we've had people ask or tell us things, but we've got no way to contact them, which is a shame. And now, after that whirlwind, I'm now up to the Q&A section of the presentation. So I might stop sharing my screen, and then depending on the questions, we can go back in or do what we need to do.
Thank you so much, Jenny. That was great. I'll definitely be rethinking my data now for my projects. And I learned a lot, as you said, being in sexual health. But the cardiac arrest data I found fascinating. So thank you so much for sharing that with us. And it looks like you have a lot on your plate coming up with all of those updates. But does anyone have any questions? While people might be typing, you can come off mute if you have a question as well. But Jenny, I want to know, you've worked at Women's Health Victoria for many years, and with the Atlas, and there's heaps of updates coming in. But in your personal opinion, what has been the most meaningful change in the Atlas?
Ooh, well, it's been a culture of gradual improvement. When it first started, which I wasn't working on it then, it had 25 indicators and they were pretty much whatever we could get at the time. But what we're trying to do more is get data that's not anywhere else. So by purchasing data from Services Australia for PBS data and so on, or partnerships with agencies that don't normally release the information. So, for example, Ambulance Victoria, their report does not really disaggregate by sex. It shows where things might be needed, but it doesn't show the difference between female and male, which really highlights these things, or the mapping of access by where patients live and where pharmacies are or prescribers. I think that's very powerful in showing discrepancies. And I think the atlas has always been done on the premise that we need to be able to tell the story uh, by sex, female and male. We're facing a challenge in how are we going to represent non-binary data, and it's the top priority of everybody, including the Atlas Advisory Group, that when we can get data, say from the census, how are we going to, if that data is good in the next census, and we hope it will be, then at least all the population and other types of census data, we hope we can disaggregate by female, male, and then whatever way we can accurately do it for other gender identities. And of course, there's no layer for that at the moment. So we have to look at that. Another challenge is, can we overlay layers that show the other boundaries of other regions, even if the atlas doesn't show them? People like to know where their area fits in, such as traditional lands, um, PHNs, local health service networks, to be able to show or turn them on or off to see how they overlay. We'd like to do that sort of thing as well, but watch this space again because it's very challenging.
Yes, I can imagine. And I really look forward the one day you get there. I can't wait for that. But thank you so much for sharing. Does anyone else have any questions? I'll give it 30 seconds. If not, I just want to thank everyone again for coming today. I hope you guys enjoyed it as much as I did and learned something new. We have another sexual wellness PD in August with Maddie, which will be on a health promotion FIFO project. So if you want to come along to that, I highly recommend signing up. But if not, hopefully see you soon and have lovely days, everyone.
And could I just say that if anyone wants customized training for an organisation or a regional meeting or a local government area, we're very open to that and we welcome any inquiries about that, which you can contact us through the survey. Um, if you would like to just ask a question, that's fine.
Amazing. Thank you, Jenny.
Thank you.
Thank you, everyone.